Recording in progress.
Can we start, Vijay? Ma'am, can we start?
We are live, sir. We can go ahead.
All right, okay. So good evening, fellow colleagues. It's an honor to once again welcome one and all of you for today's day 5th program of this Nurses Academy. In fact, this has been an initiative in collaboration with AHPI as well as ANEI, and with an intention to purely target all the upcoming nurses to get themselves updated on the recent trends in nursing and the areas of concerns and challenges. And we could successfully complete the series of webinar over the last 4 days. And today is the 5th day of the program. So today we are more than happy to welcome our the moderator for the day, Dr. Jothi Clara Micheal. I think she's a very familiar face. All of you must be aware. She's the Director of Nursing and IHHS Healthcare India. And currently she's the Vice President of ANEI and Tamilnadu State official member of CAHO, AHPI and INS. In fact, she has been so dedicated in her service. In fact, Tamilnadu government was more than happy to give her an award as latest as yesterday. That's a recent update on her profile. And we are extremely happy to have you today with us, ma'am. And we request you to kindly introduce the panelist of today, along with the topic, what we are likely to discuss today. So we request you to introduce the panelists and the topic and take the session forward, ma'am. So thank you once again, all the fellow nurses for joining for the day. And I hope today's session is going to be as interesting the way we had for the last 4 days. So over to you, Dr. Jothi.
Yeah, thank you, Mr. Raja. It is in fact a great day for us. And the entire month, we had been connecting with many nurses across India. And it is very interesting to actually be part of the learning journey. As panelists, we are learning as we host this particular program. And I'm sure you will also be able to learn and take home some messages which will help collaboratively to make nursing better tomorrow in India. So we have 3 interesting panelists with us. The topic for discussion today is professionals in critical care, upskilling competencies. COVID has taught us a lot. During COVID, there were a lot of trial and error method of learning. Some of the induction plans, the upskilling opportunities we lost, but there were newer skills we learned on the way. And there were several bedside learning that we all took to improve our critical care competencies. But I would say that it's only the hats off and big salute to all the critical care nurses, because without their support, I'm sure we would not see many of our loved ones, relatives and friends alive today. So a big thanks to all critical care nurses, and thanks to all the participants, those who have joined and signed in to listen to what we are going to speak. So in this panel, we have got 3 very interesting generational leaders, I would say. And the first person is very known to me, Dr. Jaya Kuruvilla. She is a teacher, in fact, to me. When she was doing her higher education in CMC, I was still a student. So from then, I've seen her as a vibrant leader. She has been an ex-dean, allied faculty, Maharashtra University Health Sciences, Nashik. She's also a PhD guide in MUHS, Nashik. She has on her feathers, on a cap, National Assessment and Accreditation Council Assessor and members, Secretarial Working Group, NAC. And most importantly, she's a founder and first president of Critical Care Nursing Society in India. So with this, I welcome Dr. Jaya Jambunathan to be one of the panelists from whom we are going to have a lot of wisdom and understanding about the subject. The second panelist is a very good friend of mine, a wonderful colleague. We have done a couple of assessments together, and it was always a fun when she's around us, and around our team. And she has been always focusing on professionalism and importantly among the young nurses. So in her career, spending more than 40 years, it's a long 40 years, she has dedicated herself across various hospitals and territories in India and Southeast Asia. She has played several leadership roles, and the most recent past was she was group head at Emirates Healthcare in UAE, a regional chief of nursing service at Fortis Healthcare, Gurugram. She is part of these roles, and she has worked in well-known institutions and established several projects and improvement plans across India. Now, she has been an assessor, trained assessor, and she also gets involved in training of the assessors, and she is an ex-technical committee member of NABH. She is also an accredited assessor, a task force committee member from Emeritus International Accreditation Center, and has contributed in developing these standards for healthcare. Hats off to you, madam. Thanks. And we are very happy to have you, Ms. Kawaljeet, overall with us. And it's going to be an interesting learning for all the participants, those who are here. The last panelist is a very known and close to me, working with me at one of our hospital, a young dynamic personality who has grown very steep to reach what she is today. She is Chief Nursing Officer at Global Hospitals, Mumbai, with 17 years of experience across the field of nursing education, service, and administration. And she would like to always say that she's an alumni of St. John's, and she always focuses on nurses' interest. And she broke the barrier between the leadership and the nursing team. She has got few papers on her credit, and she has been a resource person in various sessions in national and international conferences. So now we have got three eminent speakers with us. So we are going into the topic, and this panel, we are not going to have any PPT. PPT is sometimes very convenient for us, but it is not much convenient for the listeners. So after the lunch, you're all seated here. Now we want all of you to enjoy something and to go beyond what is the regular critical care components. Now our focus is on critical care professionals. So before we enter into this, the first thought that comes to us is critical care professionals. How do we define? Now, who are all the members of the critical care professionals? Can I see participants putting those professionals in the chat box? Certainly you have intensivist. You will have anesthesiologist part of it. You have some of the doctors, those who are handling patients. They are patients, that is the doctor, surgeon who have handled the patients, and they have placed their patients for intensive care in the critical care unit. And we have got the physicians, some of them getting their patients admitted into the critical care unit like medical ICU. The transplant team post their patients there for critical care team activity. Some of our ICUs are open ICUs. Some of our ICUs are closed ICUs. There are different methodologies that I use. Paper, pencil ICUs. Some of the ICUs are partially high-tech and digital, and partially they are paper, pencil, the file and the folder that you use. And some of the ICUs are high-tech and completely digital. So we have several kinds of ICUs, and there is no one single pattern. However, NABH prescribes a very clear definition about who are the professionals, those who are considered to be the team, and what is the requirement of them for a better and safer care for patients. So credentialing and privileging determines who are the eligible candidates. And now I've seen some of the chats getting posted by the participants. Of course, you need a medical team, yes. And predominantly the ICUs are headed by the intensivist or anesthesiologist. Then you have nurses, those who are critical care specialist nurses, either by experience or qualification. Then we have technicians. Some of the hospitals or most of the hospitals have got critical care technicians. Then we have to support doctors, physician assistants. And recently, when I mean recently, in the past 3 years, we have got the nurse practitioners passing out, and nurse practitioners are placed in the critical care unit, because the critical care nurse practitioner is a residential program where 80% of learning happens at the bedside and 20% in the classroom. So they are the bridge between the nurses and the clinicians or the intensivists in the critical care unit. Then we have other members, non-clinical members, like housekeeping and maybe probably somebody for billing and other things. And we also have a paramedical group of people, physiotherapists, chest physiotherapists, and we have dietitian, okay, and then the psychologists, because it's very important. Clinical psychologists are placed in the critical care unit and some of the hospital, and clinical pharmacologists. So the team is little broader and they provide an excellent care. So when it comes to critical care professionals, the one professional team who is a hub, I would say, is the nursing, because they stay without wink of an eye. They watch patients. They ensure that they escalate informations to doctors. They quicken the decisions for critical thinking and planning for the patient. And with this, I thought, like, we have a couple of questions to the panelists. When panelists are able to answer these questions, you will come to know more about the critical care professionals. So the first question goes to Dr. Jaya Kuruvilla ma'am. Dr. Jaya Kuruvilla ma'am, the question goes to you is, there is a perception that the nurses learn to deliver critical care only after getting inducted into a hospital critical care unit. Nurses are not job ready to provide care in the critical care unit. Please comment on the theory practice gap that is existing, and what are some of the means to enhance job readiness among nurses who chose to work in critical care unit. Over to Jaya ma'am.
Thank you, Dr. Jothi, Clara, for that question. And also thanks to AHPI, ANEI, and Microlab for giving this opportunity to be part of this session. Now, coming back to your question, first let me talk about the perception, the word that you have used. With regard to perception, something that we need to understand is that BSc nursing program prepares generalist, not the specialist. But at the end of BSc nursing, when they are posted to ICU, they are expected to be specialists, unlike what happens in medical profession. No MBBS doctor is called as intensivist, but our nurse becomes an ICU nurse. That is a paradoxical shift that is there between the two professions. So hence, it is not really prudent on our part to expect that these nurses coming out of the college have all the competencies that are required for them to function effectively and efficiently in ICU. But at the same time, we can't say that they are totally new to critical care, because the syllabus consists of about 25 hours of critical care and emergency nursing. Apart from that, every system deals with a critical disease condition of that particular system. For example, if you take cardiovascular system, myocardial infarction is a critical disease. So every system goes in that way in syllabus. So, but at the same time, though they have gone through this, we need to admit the fact that there exists a gap between the theory and the practice. So what can we do? So what needs to be done is we can have an augmented curriculum, which is taking care of the needs of these nurses who are in this transition from the student period to the staff nurse. In fact, in our hospital, we conduct a 6 months critical care nursing program for our novice nurses, and they are selected very carefully for that. Apart from that, there could be other programs which can be conducted, which we conduct also, because I want to talk about what can be done and what is being done, instead of talking what should be done. So we do a structured integrated practice with a preceptorship model. This integrated practice is part of the curriculum, and it is for 3 months. Then we have a paid internship program of 6 months after they have given their final year, 4th year examination. And during this time, the competency assessments are periodically carried out, and the transition from posting in general ward to ICU takes place based on the competency achieved. That is the way it is being done. Now, the third would be industry academia collaboration. We do that in collaboration with relevant industries. We conduct programs on dedicated modules, for example, ventilator care, TPN, total parenteral nutrition, or pressure injury prevention, IABP. So these are some dedicated modules which are being conducted with industry collaboration. Now, apart from this, there are on-the-job training opportunities which can be created for upskilling. It could be self-directed learning resource. Again, in our hospital, our nurses are being given the access to clinical key on their computers, which they can access even while they are on duty if they are not directly at that point of time engaged with patient care. And then web-based materials which are made available, and video demonstrating core procedures can be done. And then just-in-time training for hospital endorsed practices. In fact, this is based on some study which was done during the COVID time, because it was during the COVID time, it became necessary that we need to upskill them within the short span of time. So just-in-time training, what was required at that time? For example, calibration of the dosage of sedation to be given, or troubleshooting of ventilator. So that can be done. And then, of course, there can be other activities, the interdisciplinary education, that is very important. As we know, most of our intensivists participate in the education, and faculty lecture series can be now with the use of web series, we can make that available for them, which can be read and studied later on. And then another concept which has come about is in-person ICU skill days. The example of this is that organization of an 8-hour skill day in targeting competencies for those staff who exhibit low confidence level. And so this could be interactive sessions, simulations, drills, and which can be combined with OSCE to evaluate their competency. And all these strategies are validated by a study which was done during the COVID time. Later on, if time permits, I will share the study, but for the understanding, I think that is. And one more thing, what I would like to say, that we conducted during the COVID time, we conducted a 4CN program, a certificate course in critical care nursing, in collaboration with CCNS and Critical Care Foundation at Jaipur. It was a huge success. Ordinary nurses from ordinary hospital from a small town, 10 of them were selected, and the outcome was really, really marvelous. So that means it can be done.
Thank you, ma'am. Thank you, ma'am. That was really awesome. You never spoke anything of theory, but you gave a lot of evidence that is tested and proven in your organization and in the critical care society. So it's wonderful to actually listen to the strategies. I think some of the strategies are practiced across India in many hospitals. Some are little new and innovative. Probably, I'm sure these can be further elaborated in other sessions, or if suppose the candidates are interested, they would connect with you to learn more. Just-in-time training was really a new term that you have coined, which is very interesting. Interdisciplinary learning and training is interdisciplinary learning is truly a need of the hour. And that is the best method and the methodology that we could adopt. And advanced competencies, which are, excuse me, microlab team, please mute yourself. So modules on advanced competencies is another aspect that you have told, which is very interesting. So thank you, ma'am. And now we will move on to the next speaker, Ms. Kawaljeet. I have an interesting question for you. Excuse me, microlab team. Microlab team, please mute your mic. Thank you. Given the current scenario in nursing, competency assessment and enhancement has become a priority goal for critical care nursing leaders, nursing administrators, and educators at the same time. Nurses, those who are privileged, only are permitted to provide care for the hospital patients. Now, how would you balance this scenario? Could you suggest strategies that would prevent direct learning on patient yet enhancing the critical care nursing competencies? Because many of the hospitals, nursing students are not able to touch the patient. Unlike earlier days, the burden that the patient would share on healthcare education is becoming lesser and lesser because of increasing consumerism. So in this regard, like, I feel that the confidence of the public on a freshman doctor or a nurse is not yet there. So in this scenario, I would request you to explain to the participants and to the educators, administrators, and the leaders, how would you patch this particular gap and provide us a strategy?
Thank you, Dr. Jothi. This is a very important question. We say that, nurses should not be performing any activities directly on the patient. Let us come to the actual scenario, the practical scenario in any of the healthcare organizations. Now, India is a vast country. We are not talking only from, category A type of hospitals. We are also talking about category B, C, and even nursing homes and small areas where there are ICUs, so-called ICUs, where nurses are just posted who may not even be a proper nurse, right? So now the problem is, as soon as the nurses join any organization, the leaders feel that the nurse should have joined yesterday and she would have been posted in the ICU today. So actually, that is the biggest problem challenge for all of us, that how do we balance the nurse who comes into your organization, make her undergo training so that they are ready. Like Dr. Jaya said, that the perception is BSc nurses are generalists. So, but when they come to us, we think that, okay, they are ICU experienced girl, or we are taking them against a vacancy in the ICU, let us post them over there. That is the biggest problem. Now, again, it depends where the nurses are, which organization they are joining. Now, if your organization has got a attached college of nursing or attached a strong educational department and a study lab, you can take these nurses before they join your unit into a skill lab. And then you can make them perform activities or perform skills which are simulation-based training programs, so that they are becoming competent on the dummies, on the mannequins. They learn all the basic ICU procedures in a classroom setting. If that is possible, then it is nothing like it. You can keep them A critical care module is prepared in-house in your hospital. And I must say here, doctors, whatever I have come across in my experience, doctors are ever ready to pitch themselves and give the training to the nurses. This is very strong. But at the same time, if you see the same doctors, the day they see you, even in the lift, the first question is, I'm having huge problem in my hand. Your nurses are not trained. They do not know what to do, this, that, so the things start. So really speaking, it's a big challenge, but I still feel that every nursing leader, every in charge, every supervisor must ensure that before actually we put the nurses at the bedside, it is not fair for them, because that is again leading you to abscondees and increased attrition. They will run away, they break down. So the best is you think that these nurses have not joined your organization, they will be joining you only after 15-20 days. Take them into a classroom setting, give them simulation-based training. Even if they're posted in the wards or in the ICUs, they are shadowing a mentor, a preceptor, right? And then case studies and scenario-based learning should be encouraged. Okay, they should be given the complex case studies, because ICUs are not only critical, they are also complex. You will have different types of patients over there, and ICU is ICU, but again, you have sub-ICUs, like you have a medical ICU, surgical ICU, cardiothoracic ICU, then CCU, bone marrow, transplant ICU, liver ICU. There are multiple ICUs, and each of the ICUs, there are certain procedures are generic, common to ICU setting, but certain are very specific to that particular type of ICUs. So each and every ICU, each and every hospital, the training has to be customized to their own patient base. It has to be done as such. So you will do case studies, you will do scenario-based learning programs, then you will do skill workshops and drills, role plays, which are very, very important. Then also encourage the nurses for online learning and provide educational resources. Encourage them to attend these webinars. Like today we are having this webinar, and we have been conducting webinars on different topics from last 5-6 days. I'm sure it has benefited many of the nurses by going through this online learning and sharing of experiences and ideas. Then again, collaborative learning, mentoring, continuing education, professional development, all these are certain strategies I think we have to make sure that the nurses undergo. And the most important is, before you make a nurse perform any independent activity on a patient, please do competency-based assessment for them. And not competency-based assessment means every procedure, whatever is expected from them to perform in that particular ICU, a clinical instructor or a nurse practitioner, if there is a nurse practitioner inside your clinical areas, they can take this additional responsibility of teaching these nurses and ensuring that these nurses who are new to the system, and before they are doing practicals on your patient, each procedure, the skill is, it is measured against a competency-based tool. And then only you should put them to practice on the patients, because for a patient, for a nurse, or for a hospital, it may be just one error. Okay, in your statistics, it may go as 1% or something, but for that particular patient where the error happens, it is 100%. So really, we really cannot afford to, have such type of errors in our hands, which can be, very serious, or it can lead to mortality. I have seen certain cases happening as such also. Now, the biggest challenge over here, Dr. Jothi, what I would also want to highlight is, presently the nurses who are coming to us are COVID nurses actually. They have been trained during COVID programs. Even the nurse practitioner, I was talking to one of them. She has done an NP course for the last 2 years. Very, very low, very low.
So Ms. Kawaljeet actually was, we had a very good discussion a couple of days before. Like she was talking about, yeah, I was just completing your statement because you went offline for some time. Yeah, please take over.
I'm audible now?
Yes.
Yeah. So basically, I would say that as a strategy, every hospital must strengthen their education department. Earlier in our days, like a few years back, we had just one nurse educator and 1 or 2 clinical instructors. I personally believe that every unit must have a preceptor or a clinical instructor attached to that unit so that they are able to continue with this training and developing of these nurses in these critical areas.
Okay, thank you. Thank you. Thank you, Kawaljeet. That was a very good explanation that you had. The first point, what she mentioned is nurse educators, senior nursing professionals. Assumption is bad. So never assume a nurse has come from one big hospital or maybe a very good reputed institution where number of patients are there, she'll be able to perform better. Never assume she has a credential or a qualification, she'll be able to do it. Start from the scratch to assess what is the level with which they are entering into the organization for a particular unit, whichever critical care unit may be. And second very important point Ms. Kawaljeet brought was on simulation. Simulation does not mean high or low fidelity simulators. Simulation is simple. You bring your learning to reality. But learn everything all about the care of the patient. And this brings me to an interesting topic called as like, should we have a skill lab for nurses? Is it costly to have a skill lab in every hospital? I don't think. You can even have your tubes, lines and drains that has been used for patient ETO and keep it as an exhibition. So it's a knowledge gain for them. They can handle them without no cost because it is safe, it is clean, and it is there and they know about it. Just an example I'm giving. So like this, we could have many innovative approaches where critical care nurses are also prepared. And very interesting point she brought here was you have to set up and then scale up the candidates. We have to go from simple to complex. We have to go from basics to advanced. Rather than just assigning a patient, you take care of this patient. So these principles, if we follow, then we will be able to take them there. With less number of nurses, how do we take them there? This is another question. So we need preceptorship, which Dr. Jaya had told. So I think it is an eclectic approach of methodology that we use so that given environment, we are able to make the nurses at least job ready to the critical care level 2, where they are at least assuring safety for the patient and then progress them to proficiency in the critical care. So with this, we will move on to the third interesting question, which I have for Jessica. Critical care units demand professionals who stay for considerable time in the units so that they are constantly upskilling themselves and effectively utilized for better clinical outcome. Everybody would dream for it. And if you see average length of nurses in the critical care units, when I was interviewing few of the leading institutions and in the tier 2, tier 3 cities, in an average, if you want to calculate it, it will be like less than a year. The nurses move in given scenario, less than a year, average length of stay. So if the average length of stay is less than a year, in our organization, when we calculated, it were 18 months last. And then it was very much struggle for us to put a sensitivity indicator. Let us push this 18 to at least 20 or 22. It was a great challenge. And Jessica, how would you think the organization could extend the stay of the critical care nurses? Very challenging question for you.
Thank you, ma'am. Challenging, but a very innovative for us as leaders to think new strategies, new ideas. I'm sure everyone, as you said, each of the hospital would be understanding the various reasons as to why nurses are leaving. It would be majorly moving to overseas, or with the healthcare industry growing so fast. I'm sure most nurses are being running from hospitals to hospitals. Gone are the days during our student period when we used to see staying in the hospital for 10 years, 15 years, 20 years, and the outcome is to be so good. They used to know in and out of the hospital. But currently, if we meet any of the nurse leaders, if we meet any of the ICU in charges, the one biggest challenge which you mentioned is long stay nurse in the particular ICU, which I'm sure is happening not only in the private sector, but nowadays, even in the government sector, the nurses have been moving. And this has been a great challenge because, as we all know, the complexity of the ICUs is so high that there is intense skills that is required, as already the previous panelists have mentioned, like critical thinking skills, decision-making skills, compassionate care, technology proficiency, being flexible, being accurate. And when we train the nurses to be so skillful and competent, and as ma'am said, they leave in 1 year to 1.5 years to 2 years, they want to look into the next journey. I'm sure hospitals take care of the monetary benefits, do critical care allowances, which is one side of it. But on the other side, not every nurse leaves for a monetary benefit. There are certain engagement activities which I'm sure hospitals could take up or the nursing teams could take up. It's more important that we engage every single ICU nurse, especially the current generations who are millennials and Generation Z. They have a lot of interest and innovations. So it's important we at times break the barrier and break the culture of traditionally care being provided and involve these nurses in getting innovative ideas, evidence-based practices, as well as best practices to involve in the patient care areas in the ICU setups. Most importantly, like how we have clinical counseling for the patients. The more we engage our nurses into this clinical counseling, I'm sure they all feel partnered into a care of the patient and they feel engaged so that they stay for a longer time, a longer duration time. We always have seen the clinicians having the mortality and morbidity meetings, but the same way once we have started inculcating that into our clinical settings where as a nurse, we involve the nurses at the ground to discuss the incidents as to what has gone wrong, how could this patient be better taken care of, why the miss has happened, to capture the near miss, not only to capture the incidents, but also to capture the near miss. And this closed group discussion with the nurses would help them come up with newer ideas. And once they feel that, okay, this is the way that we can improve ourselves, I'm sure they would stay for a longer time. Most importantly, I think what we all should focus on is to provide a growth pathway or a career pathway to our nurses. Not stay at a staff nurse level for years together, grow from staff nurse to a senior staff nurse, from senior staff nurse to a team leader or a manager, as well as get involved in a lot of initiative activities. And this is important to groom a nurse or to orient a nurse at the time of joining, at the time of induction, that this is your growth pathway. After 2 years, after 3 years, after 5 years, what is your goal and how we can help you in achieving that goal is what will surely help the nurse in understanding that this is the future. I'm sure a freshman nurse, once she passes and joins a hospital, very few nurses would be thinking next 5 years down the line what I'm going to be. Even if you ask out of 100 nurses, I'm sure 80 nurses will be just going on the flow that my friend is writing IELTS, so let me also write IELTS. My friend is preparing for German language, so let me also prepare for German language. But allowing and inculcating the nurses to think out of the box, helping them to give out ideas like the initiative roles we currently have in our own hospitals, giving that thought to the nurses that this could be your future to reach to this level. This is the extended scope that is developed currently in the country or in our hospitals, which you could take an opportunity to explore. So giving such thoughts to the young nurses would give them an idea as to what nursing is and what actually extended role of nursing or nurses is. As well as whenever a new medical technology or a new surgery, a new clinical case has come up into the hospital, involving them into the trainings of this newer technology, getting new equipments, hands-on trainings on this would also help the nurses to train and to feel empowered to go further. And when I came to the word of empowered, this is a main interesting term for us. And I can see a smile on Clara ma'am's face because the current nurses, I'm sure everyone wants to be empowered to be feeling that I am an important and integral part of this healthcare team. If every patient is walking out of the hospital comfortable, it's because of the work done by the nurse. So that empowered nurse will surely feel proud and stay with the organization for a longer time. Give the nurse the power to decide for the patient what is right for the patient. Give her the knowledge, give her the competency to work with the patient, that they feel like working and to go forward. And in addition, and all the doctors in giving more appreciation to our nurses for the work that they do, they'll feel really engaged.
Yeah, thank you. Thank you, Jessica. You summed it up. It was a very tough question. I think many of us don't have much answers to it. So I would like to sum up what Jessica has told. Like, see, we can prevent preventable attrition. We are not talking about the attrition that is going to be planned and they are going to leave us, but preventable attrition. Many of the nurses leave our profession also because of the stress that is created and the environment that is provided for them to hate healthcare or nursing. So there we can prevent nurses leaving one organization, moving into another organization for a small amount of money. So these things can be prevented, and that is possible if the effort is put from the end of the senior consultants or the senior leadership position in the unit. If they see nurses staying strong, if the critical care mid-level nurses are stronger and they are empowered, they will see that their team is also empowered. And nurses love learning organization. Current days, nurses wanted to quickly learn and grow. So they would like to stay in organization where learning is happening. If learning is not happening, they would not like to stay because learning helps them to grow better. One point I would like to tell you, if any of the young nurses who are here, this panel team would like to request you saying that if you are going to leave an organization to maybe international or other placement very early with less than 1 year of experience, the level of growth that you will take is from 0 to top up. But if you go with 1 or 2 years or 3 years of strong foundation, then for you to have a career path, whether it is in UK or US or any other country, it's going to be very good. I can have evidences shared with you. Some of our nurses who have gone to US and UK, currently they are medical students and anesthesiologists, nurse anesthesiologists, and some of them are matrons in just 3 years. I'm not talking something not really happening. This is what I have witnessed. It because the foundation is very strong. So set your foundation strong is a request from us. We don't say that you should not leave the country or you should not go for a better thing. Very beautiful point Jessica brought in career pathway. India don't have, even in education system, recently Indian Nursing Council has brought in the residential programs where nurses can work and they can learn and they can get certified. Such programs are available in Indian Nursing Council, but takers are very few. So residential programs and clinical pathway where the career path is very clearly defined for them. Nurses do not want to stay in one role for maybe 2 years or so. So quick ladder for them is another area, and challenge their aspiration. Some of our nurses are very aspirant. So we have to provide environment that is very challenging. So we have to think faster than them, how to meet their expectation. So they are our customers. So as leaders, so critical care nurses are like a hot cakes. So we have to invest on this. So with this, we will go to the second round of questions. And this question goes to Dr. Jaya ma'am. Jaya ma'am, you are the first president of CCNS, and all of our hospitals have now registered to become certified CCNS ICOs. And I have also seen your standards of critical care program that you have developed. It is simply awesome. Like, it is 360-degree cover, and it gives us a lot of insight and guidelines. Now, can you speak something about CCNS in regard with upskilling critical care competencies among nurses and bridging the gap between intensivist and nurse, especially in taking timely right clinical decision for patient. Also, I want you to answer to the question, does aptitude matters? Is it only the competency or aptitude also matters in order to make a nurse successful and be a proficient nurse in the critical care unit? Why some of the nurses fail and they opt out not to be as a critical care nurse, but they want to become a generalist nurse in the ward?
Okay, thank you, Jothi. Again, I will answer your question number 2 in parts, exactly like how you have presented. Number 1, CCNS is an organization which is dedicated to carry out or implement upskilling activities for our nurses. And how do we do it? We have a decentralized approach. What I mean by decentralized approach, we have about 11 to 12 chapters all over the country for CCNS. So we encourage the chapters to conduct skill sessions for the nurses, depending on the need, what they perceive at their area. So this goes on through the chapter organizers. Apart from that, at headquarters city, that is in Mumbai, we have some of our management committee members as the nurse leaders in reputed hospitals in the city of Mumbai. So what we do is, under the umbrella of CCNS, we conduct the very specifically skill enhancement sessions. We avoid the theory totally, I must say. Just with the introduction, get on to the skill enhancement session, and which we conduct every 6 months. And again, it has been taken by different hospitals, by the executive committee members who are the nurse leaders, and in collaboration with CCNS. That is another thing. And every 2 years, we conduct an international conference at different parts. We were not able to really move out much, but we had been to Belgaum, we had been to Pune, we had been to Mumbai. And what we do is, the previous to the conference, we have a pre-conference session, again on different topics about, depending on the availability of the geographical location where we conduct it. At least we conduct 4 to 5 sessions simultaneously, focusing only on skill enhancement, which we call it as pre-conference. And then we have the continuing nursing education programs in critical care nursing, wound nursing, which are conducted by many institutions which are affiliated by CCNS. And another thing, we have a journal which is published biannually, and which updates the readers about the recent trends and the evidence-based practices in critical care. So that is answer to your question number 2A. Now let me answer your question number 2B. Do you think aptitude play an important role? Yes, I strongly believe that. Aptitude plays, and unfortunately, even at the time of admission to nursing, we very few, I do not know, at least in Maharashtra, we do not conduct an aptitude test for the nursing students in general, and in particular for those nurses who have to be appointed to the ICU. But at the same time, let us assume that a nurse has come without the appropriate aptitude. To a certain extent, some level of aptitude formation and skill enhancement can be carried out by strategies such as peer education, identifying a right role model and pairing them with them. And there is something called an innovative supervisory care models, and also initial hand-holding. So this would definitely help to a certain extent. It may not completely enhance the aptitude. And at this time, I would like to share the finding from my study, which was conducted in ICU. I found that there is something called hardiness as a personality constellation of 3 characteristics, with all 3 of them start with C. That is commitment, challenge, and courage. One, those who are committed, one who is able to take challenge. I think just now you talked about, there are few who are willing to take challenge.
Yes.
And the third one is courage. We must have seen even our students fainting when they find blood, and those kind of nurses are not the right ones for ICU. So probably for nurse leaders, when you do recruitment of nurses, to look for this personal characteristics of hardiness, which is commitment, challenge, and courage. And especially when somebody is doing job allocation of a nurse to ICU. That is my second question. Now, question number 2C. Our nurses fall out. I think Jacinda has beautifully brought out some kind of ideas to how we can retain or how we can engage them. So what I would like to say that it goes beyond doubt that a conducive environment learning as well as for practice is important for adaptation. And otherwise, there are nurses who will opt out of ICU before even they realize that they really had the potential to become an ICU.
True.
So it is very, very important to create that conducive environment. And when I say conducive environment, we understand the complexity of the ICU. In fact, when I did that study, I read one article, they compared ICU to a pressure cooker. So I am not going to explain it. You understand what happens inside the pressure cooker. And so we understand the complexity of the ICU environment. Certain stress factors are unavoidable, but still I believe there are factors which can be controlled, which can be limited, which can be reduced, so that our young nurses, they don't lose interest as soon as they are posted to ICU. Another thing I think Kawaljeet had mentioned, or 2 other concepts. One is skill mixing. It's a concept which can be implemented in ICU. Skill mix broadly is the number, the educational preparation and level of the nurses, which post they are in, and also the competency level. So based on this, that skill mixing can be done. The young nurses will develop the confidence along with being with the others. So that is one. Again, I think due to paucity of time, I'm sure many of them also.
Thank you.
The second thing is credentialing and privileging. So this is another concept which will reduce the tension among them, and so that we can prevent the fallout.
Thank you, ma'am. Thank you. Leaders, those who are here, critical care, mid-level leaders, in charges, supervisors, a great call for you. You have to ensure that do not increase the pressure of the pressure cooker, reduce the flame so that the cooker comes to a state where it doesn't whistle. So we have to take care of it, and ma'am, very nicely put, you have brought it out. The next question goes to Ms. Kawaljeet. How would mid-level nurse leaders ensure accountability or optimize diverse talent, enabling in the critical care nurses to self-evaluate them and identify potential gap and competency enhancement opportunities as they continue their upskilling journey once they get inducted into the critical care unit? So this is go into their mind, into their heart, and make them realize. So how do you think it is possible by the mid-level nurse leaders?
See, again, this is very important, and I think the previous 2 panelists have already touched quite a lot on that. And you yourself said that the mid-level nursing managers or leaders have to be strong. If we are having a strong mid-level leadership in the critical care units, I think this particular aspect of ensuring accountability and optimizing diverse talent will be taken care of. Now, some of the strategies what we can think about is when you have a group of new nurses who are with you. Again, they are Gen Z. Most of these nurses are Gen Z nurses. And this is what Jessica very clearly said. The Gen Z nurses, if we as leaders understand their inherent qualities, I think we have won the battle, right? They are, again, in our time, 20, 30 years, starting and retiring from here. Today, you are talking about 20 months. I'm also having people who are going out within 2 months. I mean, what are you going to do with that? Where is the stability, right? So Gen Z professionals of today are very clear in their approach, goal-oriented, techno-savvy. They want their results yesterday, not even today. So they're so much impatient, And when we talk about loyalty and all, that is gone by now. So we have to now look into what is that Gen Z wants with us. So as mid-level nursing managers, again, this group of nurses, they like to receive continuously feedback. They want to be having very clear goals and expectations. So if mid-level nursing managers are able to give them regular feedback and give them coaching is another very important aspect. You have to coach these nurses. You cannot teach them, you have to coach. So there's a different principles of coaching, give them regular feedback and which helps them to understand their strengths and weaknesses and identify areas where they need to improve. Now, second part is we have to encourage them to self-reflect. So encouraging self-reflection is again very important so that these nurses are able to identify their own competency gaps and enhancement of their opportunities. I mean, unless I don't know what I want, nobody can tell me what you want. I have to know what I want, I should be asking these questions to myself. What do I do well? What do I need to improve? And what new skills or knowledges do I need to acquire? And today's nurses are smart enough, they know exactly what they want and when they want to leave. So this is very important, Third is like she said that create a culture of learning. I'm sorry, Dr. Jaya, okay? Create a culture of learning. This is again very important. Let the ICU, which is a highly stressful and a pressure cooker type of environment, but still we can make learning fun. We have to create a culture of learning within our units. Okay, so here we can give them access to the training and development opportunities, peer-to-peer learning, let them discuss, celebrate their successes, even small successes if they are having, accomplishments they are having, please celebrate these things. So let this learning become fun for them. Another important aspect is use data to inform decision making. Transparency is very important. And I think objective and evidence-based data or information tells you exactly what you are and what you want. So mid-level nursing managers, they should use data to inform decision-making around competency development. That means you analyze the performance matrices, you give them the feedback from the patients or their colleagues, and other important data factors also like patient feedback or consultant feedback. We can, peers feedback. So we can give them the data so that they are able to understand where exactly they stand. One of the examples of this data is, most of the ICUs, they will be publishing their KPIs. They will be publishing their indicators. So if you know exactly where your ICU stands, and I have seen this happening, if you're having healthy competition between your units, each one of them also strives to do better than the other. So this healthy competition also makes the team understand, okay, we are a part of this and we need to improve upon that. And then again, give them ongoing support. So not that you are finished, the support has to be continuously going. So it has to be like, mentors or coaches, then giving them training or development opportunities, sending them for certain training programs or webinars or seminars or conferences. So when you keep them engaged, when you are able to, keep them along with you and make their learning fun, and help them to achieve their goals and aspirations. As mid-level managers, I think we play a very important role, not only to retain their nurses, but also to get quality nursing and service excellence. That is what I would like to say regarding this.
Thank you, Kawaljeet. You pointed it out very rightly. Now, the next question, the final round question, is going to be for Jessica. There is a huge shortage of both number and talent in specialized and super specialized critical care units. Can you opine any frameworks or any means to bridge the demand and supply by building a structural support or a structured member support for the critical care nurses, so that the priority goes with the nurses for focusing on the role that is more of clinical judgment and rational thinking that is important for patient care and the critical care?
Thank you, ma'am. This is one important question, and I'm sure all panelists, what they have spoken, but I would break it into pieces, into parts where this question would be answered, and it would be most of the summarized where all the panelists have spoken. Of course, as you said, that we do have a shortage into a specialized as well as super specialized areas. But what we'll have to focus here on cross-training from one department to other department. If we have criticality patients increasing, are our ward nurses or periphery nurses ready to take up the role into the ICUs, as Kuruvilla ma'am, Jaya ma'am already mentioned, as to just-in-time training. So this is one thing that would surely add on into supporting this ICUs into the critical care areas. Secondly is what we have identified, as you know, that the responsibility that we take over here is the core competency and the additional competencies. So if a medical ICU nurse main core competency is to take care of the medical critical care patients, what is her additional 3 competencies? To take care of cardiac patients, to take care of neuro patients, or to take care of liver patients. So in a hospital where there are different types of ICUs, if there is a occupancy fluctuation in the surgical ICU, the similar medical ICU nurse can be well prepared. We have a skill mix. We have the competency plotted on a sheet, so we know if the surgical ICU numbers have increased, how a medical ICU nurse can step up and support the other ICUs, so that we understand that the crisis is within the hospital, how we can manage the crisis and situation to support each other. As ma'am, you asked about the decision making and the rationale. It is important we give them, as already you said, to set up a skill lab. This hands-on experience of working in a skill lab and to be job-ready nurses would surely help them. Most importantly, one thing what we'll have to allow our nurses to do is to speak up. That is, they step back in a lot of the tasks. They have a lot of thoughts in mind. When we say about critical thinking or decision making, the minute they don't speak up, the critical thought will remain in their minds itself. So walking an extra step to speak up that the ideas that they have, nurses will have to change from a traditional culture of being very quiet, being scared of talking in front of doctors or being scared of talking in a team. We'll have to now start talking, and we'll have to motivate and push our nurses to speak up in front of the patients, to speak up in front of the family members, to share their critical thoughts or to share their decisions when discussion during a team, during clinical rounds of the doctors. And that will surely add on and make the nurses more strong and important. And another point what I would like to add on is over here is hand-holding and preceptorship, which madams have already told before. These simple super specialized areas would need a lot of preceptors. Suddenly, if a nurse at the bedside sees a ventilator beeping or a CRRT machine beeping or an ECMO machine beeping, the preceptor should be trained to this nurse so well that any alarms happen, what is a quick move she will do? What is a quick escalation she will do? This escalation and trainings from the preceptor hand-holding would be important at the basic level to grow on to a specialized level and to grow on to a super specialized level. So spreadsheet of this competencies will also help in developing our nurses. And most importantly, as privileges, certain special procedures could be a central line dressing or a central line care. Not necessary that all the nurses in the ICU would be privileged to do all the special procedures. We could identify senior competent nurses who are privileged to provide all type of care or the advanced procedures for assisting in intubation, and mid-level nurses should be provided with some type of privileges. This would help to balance the care across the ICUs and to make sure that no procedure is left out or no care of the patient is left out.
Thank you, Jessica. Very rightly pointed out, like you said, it is important for us to think of various methodologies where we are able to attract nurses, retain nurses, and also upskill them periodically. Now, coming to the framework, which is little emphasis that I would like to give it as a closing note, the demand and supply. The need is more, harvest is less. But what we can do is, like, even when it comes to like healthcare professionals, assistive role members those who can do the repetitive roles which does not need a cognitive thinking or a decision making. So such roles can be supported by a kind of a professionals who are a support role to the nurses. So this is not only happening in some of our hospitals, but if you see, this is a model itself in some of the Western hospitals. And this model very clearly determines the technical role of a nurse and a professional role of a nurse. So we can, I assume, and our path is towards that. And even the bill that is going to get passed has got a component on assistive role and a supportive role for nurses. I think we will move towards this. This is at one end. The other end is nurse practitioner, critical care nurse practitioner. So these nurse practitioners would take a bridge between nurses and the doctors, where they will be able to guide the nurses, lead the nurses, and also they will support and handhold, where they are not put under the pressure cooker system of conditions. So they are able to overcome and enjoy their work in the critical care area. So I think when it comes to professionals in critical care upskilling competencies panel, mind of the participants, it is heartening to see a good number of 500. Although the link is less, some have come as a group. That's what I got information from the organizing committee. 500 members have participated. This is not an evening where you come, sit and listen to the webinar, but you have done it. Thank you so much. Just 2 days for you to go for Nurses Day celebration. I know what is happening in each of the hospital, the competitions, the fun, and without deviating bedside care, there are surgeries that are continuing. There are patients, those who are getting admitted, but we don't compromise on any of the patient safety or care quality, but still have a wonderful celebration of Nurses Week. And in this week, giving dedicated time to attend to the panel, we are very happy towards it. And thank you so much, each of the participants. Thanks to all the CNOs who have deputed your nurses. Thanks to the hospital CEOs who have permitted them also to have an engagement from the hospital. Thanks to the panel. You have made the panel very interesting. All your answers have spoken wisdom, and I'm sure it will be a good thought process for many of them who are attending and those who are going to listen in the future. Thank you, Madam Jaya Kuruvilla. Thank you, Ms. Kawaljeet and Ms. Jessica. And thanks to Vijay for making all the logistic possible for us. Thanks to Mr. Rajan, who has extended and taken this platform forward in collaboration with AHPI and Association of Nurse Executive India. Association of Nurse Executives India is a very strong professional body with many of us as leaders into it. And we also collaborate with other professionals. Like recently, we have collaborated with Critical Care Society, and we have done a couple of learning methodologies for the nurses for critical care area and specialization. So you please visit AHPI-IN website. You will come to know what is happening, and we are going to have our national conference, which is going to be in the city of Hyderabad. This is on May 26th and 27th. Interested candidates can go into the website, and you can also look into the details for membership. So we encourage you to connect with leaders, connect with nurses, learn, contribute, and grow. Growth is very important. Be prepared. Opportunities are vast. Don't look for opportunity and then get prepared. Preparation is first, waiting for opportunity. When opportunity comes, you are there. You will be taken in. So wish you all the best and a happy Nurses Day. Enjoy your year. May God bless you, your family, and all the patients, those who come into your hand and care. Thank you very much.
Thank you, ma'am. Thank you, Jothi ma'am, Jaya ma'am, Jessica ma'am, and Kawaljeet.
Thank you. Thank you, Clara ma'am. Thank you, Jaya, Kuruvilla.
Thank you, Jessica.
Thank you, Kawaljeet ma'am.
Thank
Thanks
you.
to Micro Labs team. Thanks, Vijay.
Thank
Thank
you,
you.
each one of you. Thank you.
Thank you, Jothi, Kawaljeet, and Jessica. It was wonderful to be together with all of you. And
Yes,
with
ma'am.
Yeah.
Yes, ma'am. As ever.
The next program, same 3 to 4 p.m. Tomorrow also we are continuing with nursing informatics. Please do join us tomorrow.